thank you everybody here, both in the room and online, joining us for this exciting event for Alpha Tau with our key opinion leaders, both for our investors and for the broader public. My name is Rafi Levy. I'm the CFO of Alpha Tau Medical. I know none of you have come to hear me to speak. I'm not a key opinion leader in the medical space, but fortunately I'm joined by three distinguished gentlemen who are. Just quickly, I'll introduce them in order of appearance. First up is my dear colleague, Dr. Robert Den. Bobby's a board-certified radiation oncologist. After studying at Yale and Harvard Med School, he's been practicing clinically since 2007 at Thomas Jefferson University Hospital in Philadelphia, where he serves as associate professor of radiation oncology. I'm sure he'll tell you that his biggest thrill of all has been serving as Alpha Tau's chief medical officer since 2019. Next up to speak is going to be Dr. Michael Zalewski. Dr. Zalewski is professor, vice chair of radiation oncology, and chief of the brachytherapy service at Memorial Sloan Kettering Cancer Center and the Weill Cornell Medical Center here in New York. He serves as the Greenberg Chair of Prostate Cancer Research at Sloan Kettering, as well as the co-leader of the Genitourinary Disease Management Team and director of GU Radiation Oncology. And we're honored to have him as a member of our scientific advisory board at Alpha Tau from the company's very beginning. And last but certainly not least to speak is going to be Dr. Mark D'Andrea of the University Cancer Centers in Texas. Dr. D'Andrea is a board-certified radiation oncologist active in Houston, Brenham, and Huntsville, Texas. He's won numerous awards, including multiple years in Houston's Top Doctors, Patient Choice, and Most Compassionate Doctor. He's a prolific inventor, publisher of clinical research, and leader in clinical trials. Dr. D'Andrea has over 30 years treating a broad range of tumors, and we're honored to have had him leading a very active site in our US pilot study, whose results were released at the beginning of the year. So with that, before I turn it over to the various speakers we have today, I'm going to do a quick recap for those of you who are new to the story or for whom it's been a while, just to remind you who we are exactly. So, and what we'll do is I'll give a quick introduction. Afterwards, Dr. Den will speak a little bit about the systemic effects which we see from our treatment and some of the theory behind that. Dr. Zalewski will speak about some of the results from our previous clinical studies most recently. Dr. D'Andrea will speak about his experience in selected case studies from our US study. Then Dr. Den will give us an overview of our upcoming clinical trials, including our upcoming US pivotal study. And finally, I'll wrap it up with our outlook and some time for Q&A. So just as a refresher for those of you for whom it's been a while, so we are the only ones who have figured out how to deliver alpha radiation directly into a tumor for local application. It allows us to deliver an incredibly potent form of radiation directly into the tumor, and at the same time looking to spare the surrounding healthy tissue. We've done this now for over a decade. We've done this in myriad different preclinical tumor models, at this point nearly 20. We have yet to find a tumor model that doesn't respond. Every tumor type we've tried preclinically has responded. We believe that this treatment, being fundamentally physics-based more than biology-based, is in fact best suited to be a very broadly applicable local tumor control option. What's been very exciting for us, and Dr. Den will speak to this, is that where we treat one tumor locally, we find we can actually catalyze a systemic immune response. We can treat the tumor, and while the focus of the treatment is to provide that local tumor control, we also see a sort of side effect here where we are also catalyzing immune response and helping the immune system find these tumors elsewhere in the body. And so Dr. Dan will get to that in just a minute. We're going to talk to some of our most recent data. Our first clinical trial, which Dr. Zalewski will speak about, saw a 100% overall response rate and a 78% complete response rate in squamous cell carcinoma. Since then, we've treated over 100 patients around the world, over 100 superficial tumors with a very similar profile of treatment responses. In our most recent study, which both Dr. Zalewski and Dr. D'Andrea will speak about, we saw a 100% complete response rate when the tumors were measured at 12 weeks. And I think just as importantly, as you'll hear, the safety profile has been fantastic. Really, we don't see systemic toxicity coming out of these treatments. We see local toxicity in the area of the treatment, generally quite mild or moderate. We are going to spend some time talking about our clinical trial strategy, so I'll defer that for now. I will note that we've received 2 breakthrough device designations from the FDA, as you know, one of them in squamous cell carcinoma of the skin, the other one in recurrent glioblastoma in the brain. So a very broad range of tumors there, seeing that breakthrough designation. We are quite focused on our logistics, which is important for a company in our space with a decaying radioactive product, which I'll talk about in a second. We have built and are building a network of manufacturing capabilities around the world, both in the US, Israel, and forthcoming in Japan as well, looking to prepare ourselves for a future commercial rollout. On the IP side, we have over 80 patents that are granted around the world, over 80 additional applications that are pending. We think we have a very strong patent franchise around this, and happy to talk about that at a future time. And finally, you've met a bit of the team here, but I think we've got a very strong team with the right mix of skills to take this from the clinic and out into the commercial setting. So I'm going to do a very, very quick product overview, if that's okay, before we turn it over to the clinicians here. I'm going to remind you all from your high school physics class, when we look at the few different ways in which radioactive isotopes can break down, there are a few different ways they can break down. Beta and gamma decay are the release of an electron or a photon, respectively. Those are the traditional forms of radiation that will penetrate walls and penetrate the body and get stopped by metal or by concrete. We're active in the space of alpha decay, which is where an isotope will break down and release a heavy alpha particle, which has tremendous energy to it, but is also so large it is unwieldy. It's not only unable to penetrate a sheet of paper, but it also gets stopped by a few inches of air. Now, we are looking to harness these alpha particles for treating tumors. And while others have been unable to do so because of the incredibly short range of these particles, the way in which we've done this is effectively by releasing alpha emitters into the tumor in a very controlled fashion. What we do is we'll take a little piece of metal, an alpha dart source, we'll coat it with radium-224. Radium is useful for us because it'll break down 1, 2, 3, 4, 5, 6 times before it stabilizes. And most of those breakdowns will release alpha particles, which again, they won't get very far. They've got a range of about 40 to 90 microns in tissue. But what's unique here is that where the radium is fixed to the source, the rest of this chain, these daughter atoms, as we call it, they actually recoil off of the source into the tumor. They live on average 12 hours. And over those 12 hours, those isotopes will diffuse farther and farther into the tissue and fire off these particles as they go until they stabilize at the end of the chain. So as you can see here, what's happening is we're inserting these sources into the tumor directly. We're leaving them there, and as the radium breaks down, again, the radium can't leave the source, but the rest of the chain will recoil from that initial breakdown and will allow these isotopes coming off of the radium to move into the tumor. And as those isotopes over the 12-hour half-life continue to diffuse farther and farther away from the source, they are effectively extending the range of those alpha particles, not by getting the particles to move any farther, but rather by bringing the isotopes deeper and deeper into the tumor. And so now we get about a 5 millimeter range around that source to be able to treat those tumors. And so what we'll want to do is we will want to inject these sources into the tumor, space them a few millimeters apart so we get good coverage. We've developed a number of ways for doing that. I'm not going to go through all of them. Some of them are here in the back of the room for the benefit of those who are here live. We also will have some videos on that during the course of the presentation. Just to give you an example here, for superficial tumors, we will actually just inject these with a needle directly into the tumor, coming in on one side, coming out the other side, leaving the sources inside of the tumor. Now, they will be continuing to release this radium for about 2 weeks. This is a single treatment regimen. There is no need to do this repeatedly. And so we will inject these sources into the tumor, leave them there for 2 weeks. Patient comes back 2 weeks later, we snip that string, and we pull the sources out, and they're good to go. And we have other applicators as well. In the back of the room, you can see our loading device, which is used for the pancreas, for example. The example here using the pancreas is basically piggybacking off of the way in which the doctors are already biopsying the pancreas today. One of the ways they'll do that will be to take an endoscope guided by ultrasound down to the GI tract, to the stomach or the duodenum, perforate the abdominal wall with a fine needle aspirator, and take some samples of the pancreas for a biopsy. What we're doing is using this loading device, which loads any standard fine needle aspirator with these darts. The doctor is doing the exact same procedure, reversing the flow. Instead of pulling out samples, they're pushing in these darts. And so this is just one example of the way we've tackled this problem. But again, you will hear about some of our newer ways during the course of this presentation. Last thing I'll say, just to frame sort of the discussion from the business side around how we think about the commercial opportunity, with a treatment that we believe is fundamentally indifferent to the nature and the histology and the location of the tumor. So we need to figure out where we want to focus our time. And we've defined for ourselves 3 core pillars of our therapeutic focus. The first one we call the localized and unresectable. These are the tumors that may have other available options, like squamous cell carcinoma, like prostate cancer. But the patients who are not being adequately served by available local therapies, like surgery, like local radiation, often find they run out of those local options and they even need to go to a systemic therapy for what's fundamentally a localized tumor. And as we've seen from some of these trials that we'll talk about in a bit, we believe we can add quite a bit of value there in providing a more promising local treatment alternative. The second one is the high unmet need. So again, if you have a treatment which is indifferent to the nature and the histology of the tumor, you may as well tackle those tumors that have the fewest available options. So ones that come to mind include glioblastoma, pancreas, et cetera, tumors, and unfortunately the prognosis is quite poor. And then the final one, which Dr. Den will speak about in a second, is this idea of using this local therapy for treating metastatic tumors. Because we find that we've actually been able to demonstrate a catalyzing of a systemic immune response to the treatment, which again is not our primary focus. Our primary focus is treating the local tumor, but we have a nice side effect that we're awakening the immune system to the presence of the tumor. So the ability to combine this treatment with other systemic therapies like checkpoint inhibitors opens up tremendous new opportunities for us in the way we treat metastatic patients. And of course, the way we examine the commercial opportunity reflects these different ways of thinking. Whereas, for example, the first pillar, right, those localized and unresectable later line tumors, we will stratify that patient population to find those patients who are not being adequately served by those who are by those available local therapies. It may be a different approach for some of the high unmet need tumors. All right, even if you look, for example, this is just showing you up to 1 million new cases a year diagnosed just in the US of squamous cell carcinoma. Now, from the literature, we can see that around 90% are getting surgery, about 10% aren't getting surgery and are going for radiation. But we see that when you examine the recurrence rates after surgery or after radiation, you still see almost 60,000 patients a year not getting adequate relief from their available local therapy, their first-line therapy for a localized squamous cell carcinoma tumor. And so even when we stratify these patients and go after the ones who have failed other available therapies, unfortunately, it's still a pretty large number. The approach, of course, is quite different when you think about the high unmet need, that second pillar. If we can ultimately demonstrate efficacy in a tumor like pancreatic cancer, we wouldn't think about stratifying patients in the same way. We would ultimately hope to target this as a first-line treatment for almost all patients, considering both, first of all, how miserable the outlook is for those patients, and second of all, considering that we ultimately hope to pair this with some of the immunotherapies they might be getting anyway. And so that the method of thinking about the markets is quite a bit different. So with that, I want to turn it over to the gentleman who joined us here today. I will say, just to give you some framing for how we're going to do this, as we talk about the impact of the DART in treating a tumor, we will have Dr. D'Andrea and Dr. Zalewski speaking about the local control elements of how we treat that particular tumor. But before we do that, I want my colleague, Dr. Den, to speak about the systemic effect, how we see treating one tumor actually driving an effect on other tumors elsewhere in the body. So thank you very much. I'll turn it over to Dr. Den.
Rafi, thank you so much.
You got a clicker there.
Great. So it's my pleasure to be speaking to you today. So what I'd like to do is just walk you through a series of experiments that we've done that really have laid the foundation for the understanding of the potential awakening of the immune response to DART treatment. And what I will do in the course of this talk is also explain to you the unique properties of DART that facilitate this in a way that is different and unique from standard therapy options. So what I'd like to do is just take your attention here. So what we did in this experiment is we started with a naive mouse. So this is a mouse that has no cancer in it, has never seen cancer, has never seen any treatment before. And what we do is we inoculate it. In this particular experiment, what we did is we inoculated it with a colon cancer line. And as you would expect, these mice develop colon cancer in approximately 2 to 4 weeks after injection. And so then what we did is we actually treated these mice with 2 different regimens. Either we treated them with a DART seed, DART source, as Rafi showed you before, with immunomodulators, or we just treated the mice with immunomodulators alone. Now, these immunomodulators are not cancer-specific therapeutics, but rather there are drugs that are designed to augment and increase the immune system. So they consist of low-dose cyclophosphamide, sildenafil, which is known by its commercial name Viagra, and CPG. So we basically use a viral mimetic, and we use two medications that will decrease T regulators and MDSCs, which are both immunosuppressive cells. So we've basically activated the immune system, and then we've treated either with DART or with placebo. What we find, and as my two colleagues will talk about, is that when you look specifically at the local control, you see that when you add DART, as one would expect, you have a high level of local control, 75% in this case in a combination versus 14%. But that's not the purpose of this experiment. What we did is we took any mouse in which they either had a complete response or where we could remove any residual tumor. So now these mice are considered tumor-free. And now what we do is we let them live for 4 months. So they're running on their little wheels, they're eating cheese, and they're enjoying their life. And they are essentially cured of their cancer. And so now what we did is we re-challenged the mice. So what we did is we re-injected the same colon cancer line, but at a much higher tumor burden. So you could imagine this is the clinical setting of a patient now developing recurrent disease, but in a much more aggressive fashion, which is what we see clinically. So we've re-challenged these mice now with a much higher level of cancer. And what we do is we compare the growth of this cancer in the re-challenge with no further treatment. And so what we found, which was very interesting, was that in the mice that were previously treated with both DART and immunomodulation, they had less growth of their tumor. But not just as compared to control, which you can see here in blue, but also as compared to immunomodulation alone. So what that told us right away was that the DART was having an effect on this response. Now, we didn't know if it was an immune-specific response. It potentially could be an inflammatory response, meaning that because we introduced the DART, there was such an augmentation of a deranged immune effect that regardless of what kind of cancer you delivered, nothing would essentially be able to take and regrow. So to test that, we did a second experiment where, again, we took a naive mouse, we injected it with the colon cancer line, we let it live for another 4 months, but now what we did is we re-injected it either with a breast cancer line, so a new cancer type, or the same colon cancer line. What we found is that when you take naive mice and you inject them with either colon or breast cancer, they all develop breast cancer and they all develop colon cancer. When we take the mice who had previously been injected with the colon cancer line and been treated and cured with DART plus immunomodulation, what we find is they all develop breast cancer, but none of them develop colon cancer. So what this told us is the effect we're seeing is not just a DART-specific effect, but now it's a cancer-specific effect. So we were not having any impact on a new cancer, but when we resubjected to the old cancer, the body of the mouse essentially recognizes this as foreign and is able to attack it. But what we didn't know at this point is were we really making a change in the immune cells themselves? And if we were, then we could almost think of this like a vaccine. So for this purposes, what we did is we did another experiment, which is where we took splenocytes, so cells from the spleen of either a naive mouse or a DART-treated mouse, and then transplanted them now into a naive recipient and challenged those naive recipients, again, with either the colon line or the breast cancer line. So these recipients are receiving no cancer therapy alone. All they're getting are the immune cells from either a previously treated mouse or a previously untreated mouse. What do we find? When we take donor cells from an untreated mouse into an untreated recipient, they all develop breast cancer and they all develop colon cancer. When we take immune cells from a previously treated mouse that had cured itself of the colon cancer, they all develop breast cancer, but only 2 of the 12 develop colon cancer. So what it shows us is that we've changed the immune repertoire in the mouse by previously treating them with DART and immunomodulation. So this led us to say, well, what happens when we combine it with an actual cancer therapeutic? So as you're all very familiar with, the hot item in the cancer world right now is the checkpoint inhibitors and the immunotherapy. So for the purposes of this experiment, what we did is we took a mouse and grew a squamous cell carcinoma line, SQ2, which is a murine line, and treated the mice with either nothing, control, DART alone, an anti-PD-1, a murine anti-PD-1, so basically a checkpoint inhibitor, the equivalent of Keytruda for mice alone, or the combination. Now, it's important to note that when we treated with DART, we didn't look to cure the mouse with the DART treatment. We basically wanted to see what would the impact is if we just give DART, activate the immune system, and then treat with the checkpoint inhibitor. And so here you can see in black is no treatment at all. In red is anti-PD-1 therapy alone. So this would be as akin to giving a patient checkpoint inhibitor alone. What you can clearly see from this graph is that this particular cell line is unaffected by the anti-PD-1 therapy. We essentially have what's called colloquially a cold tumor. In blue, you can see treatment with a single DART seed. And in green, you can see the combination of the DART and the anti-PD-1 therapy. So essentially what we've done is by introducing DART with the checkpoint inhibitor, we have made a cold tumor hot. And what we see is that we have essentially a super additive effect of the combination of DART and the checkpoint inhibitor. When we look mechanistically, what we see is something quite interesting, which is an influx of T cells, specifically tumor infiltrating lymphocytes. So here you can see is treatment with anti-PD-1. There is a few cells here, but here you can see when we treat with a higher, we treat with combination of DART and anti-PD-1, we get a much higher and more brisk infiltration of, in this case, CD3 positive T cells. We see this true for CD4, CD8. We also see activation of the immune system with markers such as granzyme B. So clearly what we're seeing here is the impact of DART on the checkpoint inhibitor response, that it's able to drive this response further and further. Now, there are two properties of DART which make it very, very attractive with the combination of anti-PD-1 therapy. One is that because we're inserting the sources directly into the tumor, we have a very sharp fall off of the dose gradient. One of the challenges with using external beam radiation therapy in combination with checkpoint inhibitors, and perhaps one of the reasons why we haven't seen the success that we would envision with that type of therapy, is that a lot of times with external beam therapy, you're basically depleting the local T cell environment. Because the radiation field will include the T cells that are surrounding the tumor, and those T cells tend to be very, very radiation sensitive, you're essentially wiping away all the effector cells that you want. Whereas with DART, because we're placing it directly into the tumor itself, we're actually preferentially sparing those peripheral T cells, which when you look histopathologically, sit in and around the outside of the tumor. In addition, because of the properties of alpha, where we're causing double-strand breaks and we're causing destruction of the cells, especially in and around where the source is placed, because of the high levels of radiation that we're able to achieve, we are actually able to promote a much higher degree of what's called neoantigens, or basically new proteins that are being expressed on the surfaces of these cells, further augmenting the T cell infiltration. I just want to show you one patient that we treated on our first trial. Dr. Zalewski will speak more about this trial, but this patient was unique in that they were a patient that we treated in Italy, and for logistic reasons, although they had two tumors, we were not able to treat them simultaneously. So the idea was we would treat one tumor first, and then a month later, we would come back and treat the second tumor. We elected to treat the tumor here on the right leg, given its size of 3 centimeters. What we found is that a month later, there was a bit of scarring. We took a biopsy of it to prove that there was no cancer on the specimen, and we saw that this patient had no disease here. But what was most surprising, and I think important for the purposes of this talk, is that the contralateral leg also had a tumor simultaneously. And again, when we came back a month later, we had prepared with our kit and with all of our sources to treat it. We found that the tumor had basically disappeared. And so when we rebiopsied it, we found that there was no tumor on specimen. This was treatment with just DART alone, but what you can see is it shows the potential benefit of treating one leg and actually having a response on the contralateral leg. We know this could not be from the radiation itself because, as Rafi mentioned to you before, we can have the diffusion of several millimeters, but we can't have the diffusion from one leg to the other. So the only possibility is that this was able to invoke an immune response from treatment of one site that was able to be seen in the other site. So with that, I will turn it over to my colleague, Dr. Michael Zalewski.
Thank you very much. And it's a real privilege to be here and speaking about how this was titled as a revolutionary form of treatment. And for full disclosure, have been a consultant for the company. In fact, before the CEO had come along, Uzi Sofer, I was familiar with really this product in its earliest of forms, preclinical, dating back into the 1990s. And I recognized at that time that there was a tremendous potential here, but it was never realized. And with the help and vision of Uzi Sofer and the company moving forward with the whole product, and not only that, with moving forward in human trials, starting off in Israel, which we'll talk about right now, we were able to see the realization of what we heard about now, from the theoretical to the actual being realized. And that's what makes this so exciting. It is clearly innovative and unique, and I hope to, with the results here, to at least clarify and really show you what specifically is unique about it. And I was asked during, right before we had started, this is not like any drug that is experimental. Radium has been around for a century. What really, and very eloquently explained by the two previous speakers, was the unique aspect of the way this radium is delivered. It's recognized right now in our field of radiation oncology that alpha source is the most potent form of radiation around. The question is how to deliver it best, how to localize it within a tumor, and how to make that translate into a clinical result. So I'm going to show you the results from the first clinical trial, which was really exciting, and it was a bold move. I think in this country, it would have been hard to get this initiated, but with the courage and with the foresight from the group in Israel, and in particular, Dr. Aaron Popovzer, and at Beilinson Hospital, this moved forward as a clinical trial in humans. Where was it focused upon? Basically for skin and head and neck squamous cell carcinomas. I must say that at Memorial Sloan Kettering, we used typical gamma or sources of radiation about in the early 1990s, where in a similar population, we saw about a 30% response rate. Just keep that in the back of your mind. So here with the DART source, looking at skin and head and neck squamous cell carcinoma. So it is a unique group of patients, but these are accessible tumors, visible, and that's why these tumors were chosen. The lesions were not huge, but not insignificant, less than or equal to 5 centimeters. And also note, really, these patients, while some of them were first-time disease manifestation, the bulk of these patients had recurrent disease, previously radiated, previously underwent surgery. This was not a group of favorable type of tumors. These tumors have a tendency to certainly recur. The treatment, similar in this group, and again, this was performed in Israel at the Beilinson Hospital, and also in Italy, as you heard from Dr. Den. The sources were inserted under local anesthesia, outpatient setting. In other words, even though these patients were on the older side, median age was actually 80, these patients were able to get the procedure in the hospital at a day setting and be discharged. And what was done, alpha sources were inserted, and they were removed, as you heard from Dr. Den, about 2 weeks later, and then followed closely. So Initially, 32 subjects were screened, 5 were excluded, 27 subjects were treated. Some of them had multiple tumors. That's why 31 cases were actually treated in 27 patients, 3 excluded for various reasons. And so the primary focus of this study, which was actually published, was 25 subjects. 28 complete cases or tumors were actually treated. And here we see something really incredible, which you just don't usually see. And that is a complete response rate, visible eradication of the tumor in close to 80% of the patients. Partial response, which means at least 50% reduction of size in 21%. In other words, there was a 100% response rate, which is something obviously you don't see in drug therapy or the like. And so, as I mentioned, this study was published. First author was Dr. Aaron Popovtzer from Beilinson Hospital. And these figures highlight what I just mentioned: complete response rate at 78.6% of the patients. And it's this group who manifested a complete response were more likely, as you would expect from just basic principles in oncology, to have a durable response. If you were able to get a complete response and complete eradication of the disease, you were likely to maintain that without a local recurrence, more likely than among the patients who had a partial response. And obviously the key in general in oncology is that you want to achieve as great a likelihood as possible of a complete response to have a durable response as well. Here's an example, and you'll see more from Dr. Andre, of what was actually done in the patients in that pilot study, which he was very influential and important in completing. And this is a case from the original study, a scalp lesion. You can see the ear here. So this is a tumor, skin cancer on the scalp. It's a complicated situation to treat. Why? Because the flap of skin is very thin. And even with external radiation classically, these patients usually have skin breakdowns. It's a very difficult area to treat. You could see very clearly here the ulcerated area of the cancer on the top of the scalp. And with the insertion of the darts, as shown here, and again, these are the buttons, and the sources are embedded just underneath the skin. And here, basically a month later, the skin has completely healed, and it's really hardly noticeable anymore. A very clear example of a complete response, as we've talked about. What about the safety? That's always a concern. And fortunately here, if you just look at the severity grade of or incidence of side effects, and again, this study was focused on acute or toxicity experienced during and around the 3 months after the treatment. Grade 3, which is more serious toxicity, was not observed in any of the patients. In grade 2, which means the requirement to treat these patients with some minor or conservative medical management, was seen only, as you could see here, in about 20–30% of patients. And really all of these patients ultimately with conservative management had their toxicity resolved. And so the take-home points here is that from this initial study, which was published and actually generated a great deal of enthusiasm at the time, an editorial in the International Journal of Radiation Oncology, Biology, and Physics was generated reflecting the interest in the field. It is a targeted treatment, as we've heard from Rafi, just by the nature of the physics of the way the alpha particles are delivered within tissue. No systemic toxicity. And again, if everything is so confined, you wouldn't expect that systemic toxicity, always a concern, especially for radium, but nothing like that observed. Minimal local toxicity, as we talked about, grade 2 side effects, which in the case of skin would normally be ulceration of the skin, inflammation of the skin, which gradually healed on its own with time. Safe procedures for the ones doing the actual delivery. Again, because as we heard from Dr. Den, the real focus, the fall off is very limited. So it's not spreading throughout the room and a concern for the caregivers. And no suppression of immune system observed. And in fact, what is most exciting, what we heard from Bobby, is the potential in this, in a way of enhancing the immune system, and together maybe with checkpoint inhibitors, that the ability to eradicate disease, even on a local level, could be enhanced with the concomitant delivery of checkpoint inhibitors perhaps as well. And so when the company went to the FDA, and they were really pleasantly surprised to not just see mice data, but human data as well, there was really a strong interest in saying, well, I'll do this study in the United States and at least do a pilot study of 10 patients. And let's see if these results can be actually reconfirmed in this pilot study. Again, a pilot study limited to superficial and soft tissue disease. And once again, as we've seen, the eligibility criteria, similar to what was really designed for the initial pivotal study, the skin or superficial soft tissue, the lesions, again, limited to 5 centimeters or less, and anything that is suitable, amenable for percutaneous, the placement of needles within the skin to be able to deliver the DART sources. The treatment procedure, really, as we saw before in the first study, and the timeline, again, exactly the same, because that was the whole purpose, to recapitulate and redo this study and reconfirm the findings. What was amazing here is due to the credit of really a very organized staff and of course the practitioners as well, that once the study was started in July, it was completed in October 2021. So a relatively short period of time to accrue the patients and get things going. And finally, the last patient out in terms of assessment of outcome of results a number of months later. So really able to generate these results relatively quickly because of, I think, the enthusiasm of the radiation oncology community, of the surgical community, of the medical oncology community as well. And so here are the characteristics of this 10-patient pilot study. Nothing unusual. The median age here is actually lower than the first study, 70, and basically a split between male and female. Basal cell carcinomas were allowed, squamous cell carcinomas, and these were localized disease, stage 1 and stage 2, confined disease as well. The tumor sizes, median size was 2 centimeters, but it ranged as high as almost 13 centimeters, which would require the placement of more darts. It's certainly doable. It expands the time of the case, but the size is not really going to matter that much if you cover the tumor well, and that is the key. So here are the safety results. There were total of 22 adverse events, but what kind of adverse events are we talking about? Grade 3, none, nothing serious. Grade 2, again, it's a small study of 10 patients, but there were several grade 2s, which is not surprising. We're dealing with skin cancers and soft tissue tumors that could be develop inflammation and ulceration, which gradually, as we know, routinely heal on their own. And that's what was observed. And these include dermatitis, inflammation of the skin, joint range motion. And I must say, I'm not even sure that was really totally related, but it was unclear. Pain in the area, which resolved, and wound infection, appropriate treatment with antibiotics and conservative care had helped resolve that. And so finally, all 10 subjects in this important US study had a complete response, complete eradication of the disease, visible eradication at the 12-week follow-up visit. They're being followed, but again, this really reconfirms the initial study and no reported relapses of disease by the final study visits at 24 weeks. So again, to summarize, what we have observed with the second study is confirmation of the unique aspect of DART therapy delivery, an excellent local control response, and number two, a very not only effective, but a very safe form of therapy. Thank you for your attention.
Okay, let's see if I can get this here. Good morning, my name is Mark DeAndrea. Thank you. I'm from the University Cancer Centers in Texas. My history is interesting in the sense how I got involved in even skin treatment. Out of training, I lived in East Texas, so you can see by Tyler along with Paris, which is south of Oklahoma, about 15 miles. There's a lot of cancer there, so we'd see patients come quite frequently to the clinic, a radiation center, and there was no dermatologist around. An older radiation oncologist, being very practical, said, well, why don't we just biopsy them? So we end up becoming dermatologists, if you will, and would probably biopsy about 600 sites a year. The farmer would come in with a lesion here, a lesion here, a lesion here. So sometimes at 4 or 5 on each patient. So long story short, we saw a lot of skin cancer. The biopsy rate was about 50% positive. So at that time, because people lived far away, 50 miles, 75 miles, the round trip would be 100 miles a day to get treatment. Very impractical at that time. We developed a superficial radiation technique where they'd come in 2 or 3 times a week instead of 5 days a week to get their treatment. And over time, that worked very well. I subsequently moved to the southern part of the state in the Houston area and have 5 now centers that we operate out of, the Huntsville, Brenham area, College Station's in there somewhere if you're an Aggie, and the Houston area and suburban areas. So we cover hundreds of miles basically of rural as well as suburban and urban areas in Houston. And we see a lot of different cases being squamous and basal cell cancers. Again, treatment in the past, the external beam radiation therapy after either a biopsy or surgical resection if recurrent. Some of the patients though that came in were very unique, challenging. They'd have lesions in their fingers, in between the fingers, on the toes. Very hard to treat with external beam radiation therapy, so I had to figure out another way to do things. Being a tinkerer, I developed many patents, and one of the patents I did was using high-dose radiation, HDR radiation therapy, and devices where we can actually fit the patients with gloves or other types of superficial devices and treat them with the high-dose radiation. Again, so that was my background as far as my interest in brachytherapy and skin treatment. Subsequently, recently, because of the immune modifiers, targeted therapies, and immunotherapies, I developed interest in also how that works. So as Dr. Den and Dr. Zielinski talked about, the effect of Ascobal effect, Ascobal meaning treatment here, seeing a distant effect, is basically modulated by the cancer being irradiated, the cells being destroyed, the piece of the cell, maybe a protein or something, is sent out in the circulation. The body comes up and eats them a little bit and takes them and stimulates your immune system. Then it turns on your immune system saying, hey, that's something we got to go kill. So then it turns on the antibodies and go eats up the cancer. So basically treating this here kills the cancer on the other somewhere else. With that, I was at many astro meetings and saw a wonderful person who had this strange little seed called alpha seed. Alpha seed was really unique because no one existed. Over time, the product was perfected, and then Mr. Sofar got involved and took this from a theoretical idea to a commercial idea, and here we are today. the cases we saw range from head and neck areas to areas of the wrist and also on the chest wall. Some of my present today is going to show you a kind of idea what we'd see normally in these treatments. Good. By the time I'm done here, he'll finish them off here. It's great. So the first patient was a 77-year-old gentleman who had a recurrent basal cell of his nose. He had been previously treated like 8 or 10 years before, and the lesion came back and he didn't want a big surgery. So they said, hey, guess what? There's a new trial, so come on in. So sure, we took him on, and we did is basically he had a lesion here. There's a point here somewhere, right? The lesion here, and then we put the darts in. This is immediately after removal of the dart. You see kind of erythema, redness, looks kind of nasty. That's kind of the effect that Dr. Zielinski was talking about. Very localized, but not painful at all. And 12 weeks later, I guess we went to the next one here. It had another effect. Thank you. 12 weeks later, again, he's without disease. Complete response, looking great. Another lady here. She was a 92-year-old lady. She lived by herself in a rural area, but couldn't come back and forth every day. So she had a biopsy, and this was area that was recurred. So we brought her in again. Lesion, the implant. Right afterwards, it looked like she had like a rash when you fall down, kind of redness right there. Not painful at all, not painful. And then 12 weeks later, perfectly healed. No disease recurrence. Another gentleman, actually another lady, she was a patient of mine. She actually had a breast cancer and lymphoma and didn't want to have any surgery. So she said, I'll do anything, but if you don't have to, cut on me, I'll do anything you want. So I said, oh, I have an option for you. And she actually looked at the option and decided to do it. So she came in with the biopsy positive. We implanted her. Again, you see the redness right there, not painful, a little thickening, and 12 weeks later, no disease. Another lady who had basal cell on the nose, she had resection before, and I want to point this out right here. See, that's where she had her previous surgery. So they resected her nose, flapped it over. Now she had recurrence right at the flap. She did not want any additional surgery. Said that once is enough. So again, lesion, implantation. Immediately after removal, a little redness there. You see it's not so brisk as the other ones. And then 12 weeks later, completely cured. She had powder on that day of her nose. That's why it looks kind of the whitish stuff that's powder for the nose. Now this fellow was very interesting. He actually had prior cryosurgery to this lesion, but also had it basically froze or burnt twice prior to seeing me, and this was like a third recurrence. The tumor actually, I'm going to push to the next button here. The tumor actually was here in the lower aspect of the eyelid, but also involved the lacrimal duct. Now that's very hard to treat because basically you have to go in, cut the lacrimal duct out, reconstruct it with microsurgery. So the oculoplastic surgeon, actually, I brought them in to look at this. And they told the gentleman if this treatment would work, it'd save them a lot of grief because they'd have to go and basically go underneath the orbit, move the orbit, and do some surgery and put it back together, which he wasn't so happy about. So we brought him in and we implanted him. That's a little eye shield, that blue thing. He's not a Martian. That's a little eye shield right there. And this is what it looks like with the CT scan. This is all the seeds in place. So it's very close to the orbit, but because of the shield, it's protected, so it didn't hurt at all. And this is immediately after the lesion sutures removed. I think we have a little video too after this. Click with the next one. Okay, here we go. And here's this gentleman.
I'm Cyril. I'm from Sealy, Texas. I had found out I had skin cancer on my face from my face doctor. So he checked it out. He had heard of Dr. DeAndres here in Brenham, that he does the dart. So went to him.
Cyril was a unique case. He had seen a dermatologist and had multiple freezings of a small lesion that became bigger and bigger toward the inferior part of his eye. When I saw him, the tumor had grown into the lower eyelid and also into the lacrimal duct. I had him seen by one of my team members who's an oculoplastic surgeon. She explained to the patient that for her to do surgery would be extensive surgical removal and plastics repair with even some necessity for going intraocular and making sure the tumor was not there.
Back looking at my options, basically one option was to have major surgery. While they're doing the surgery, they cut out a certain part and then they come back to see if they got the cancer. If not, they have to go back, take out more. Well, when I found out about Dr. DeAndres and the DART, it seemed like it'd be the best thing to do at that time. Plus, the healing time was so much faster.
When I decided to use Alpha DART on this patient, several of the factors were important. Conformality of Alpha DART's ability to treat. This patient had recurrence, and the organs at risk for radiation were a key factor in me considering this treatment. Other brachytherapy products could not match the conformality of the Alpha DART products.
Never was in any pain or anything. The biggest thing was I was worried about, am I going to be blind from it? And for 2 weeks before the darts came out, I really couldn't see nothing but blurry out of it. And the day I went to get the darts taken out, believe it or not, I could see out of the eye.
Cyril actually had a great response. On follow-up, he had complete resolution of the tumor involvement in the lacrimal duct all the way down to the skin, and excellent response.
I would recommend it to any of my family members, any of my friends. I had it done and I said, I'm real well pleased with it.
So by the way, the reason he couldn't see is because we put a contact lens in there and it got foggy. So that's the only reason he couldn't see for 2 weeks. Once I took the contact lens out, I said I could see now because it was foggy. So we did it as a protection mechanism. Again, a little piece of paper, so he did very, very well. So thank you very much, folks.
Thank you, Mark.
Thank you, Mark, so much. That was excellent. I just want to pick up on two quick things before I jump into our clinical studies. I think that Mark's is unique in his practice setting, but also very generalizable to the U.S. population. Being in New York, we think that we have so many excellent academic medical centers here. So we think all of cancer gets treated in academic medical centers. But the vast majority of cancer is actually treated in centers like Mark's in the community. And having such a large country, we tend to forget that the nearest cancer center may be tens or hundreds of miles away. So having a treatment that can be done one time is really a game changer for a lot of these patients. So I think it's an important aspect to keep in mind when you think about this. And also the thing about Mark is that he's able to explain it, I think, to the patients in such a clear and understandable way at their level that that's another key component to this. And as we move this product forward, part of the process is the education, not only to the physicians, but also educating the physicians on how to really speak to the patient so that they can understand it and bring it down into a very tangible way. So it's very exciting for me now to give you a glimpse into some of the upcoming clinical studies that we have, including our US pivotal study. So I just would like to start this by just talking a little bit about our guiding principle. Having an academic background and having previously run a lab, I really see the importance of the preclinical side influencing the clinical side. But one thing that I've seen over my experience is that a lot of times there's a disconnect, whereas companies or investigators will design a protocol in the preclinical setting one way. When it actually goes to the clinical arena, there will be major changes to it. And the problem with that, the inherent flaw in that, is that if you don't recapitulate what you do in the preclinical setting in the clinical setting, then a lot of the assumptions by which you made your clinical trial are faulty. And I think that's a major reason why we see a lot of products falter in the clinical arena. So what we've really tried to do, and what we're doing now by building out a 4,000 square foot animal facility in our headquarters, is to really design preclinical studies that will mimic the clinic. And what we also do is we build into our clinical trials translational endpoints, which will then test and either confirm or deny the preclinical science. So it's really cycle. The other thing that we've really emphasized is in looking at combination therapy of FDA-approved agents with DART. Although we see DART as having a huge potential for marriage with multiple different novel agents, we really want to start by setting the foundation with those approved agents initially. So meeting the three pillars that Rafi talked about before, I'm going to show you and go into a little bit more information on our different clinical trials. And really, if you look at our clinical trial pathway, it's basically a continuum moving from the superficial tumors to internal tumors. And so for the superficial tumors, we can do what's called temporary implants, meaning that we can place the sources in for a time and then remove them. And for that, we have actually completed a pivotal trial in Japan for head and neck cancer. We're actually submitting that in the process of submission to PMDA for that. We will be initiating a US multi-center pivotal trial. This will include 86 patients, and I'll go over this in a little bit more detail in subsequent slides. And as you saw already in the US pilot trial, but we're further expanding it to other histological types besides just basal and squamous, Merkel cell melanoma as well in Israel. Now, as we move to internal organs, it's very important, I think, whereas with superficial, you can easily visualize the response. For internal organs, we really want to understand, is the dosing appropriate that we're using? Are the side effects, what we're seeing, are they correlating to actual pathologic results? And so for those purposes, we've moved to a neoadjuvant type of approach in several different disease sites. The first is a trial that we have open in Israel, where we're actually implanting DART prior to surgery to lesions that are seen either on MRI or PSMA PET. I'll explain this in a little bit more detail. The patients are then going to surgery, so we will have correlation between radiologic response, PSA response, and pathology. And that will help us, so when we go into other settings within prostate cancer, to ensure that what we intend to treat is what we're actually reaching. A second study that I want to highlight is a liver trial. This is for patients with metastatic colorectal cancer, and they have liver lesions, and they are undergoing a 2-stage hepatectomy, and I will go into further detail on that. Finally, we have a trial that we're opening up in Israel now to deliver neoadjuvant DART in the setting of breast cancer. Again, this will serve as the basis by which we can then go into other indications within breast cancer. We've also thought on that third pillar, looking at the unmet need in the inoperable patients. So we have a trial in Israel and in Canada looking at pancreatic cancer, delivering the DART seeds using an endoscopic approach, as you can see in the back of the room. We have an additional liver approaches using percutaneous methodologies, breast cancer trials for inoperable patients, as well as for patients with recurrent GBM that will be opening both in Israel and the US. So that is basically the overview of the thinking behind our clinical trials. So I'd like to go through a couple of them in further detail. The first is our US pivotal trial. So this trial was submitted to the FDA and will be submitted when completed for marketing approval. This trial is for patients with recurrent squamous cell carcinoma. The primary endpoints of the trial are overall response rate based on best overall response, duration of response rate 6 months after initial response, and safety analysis per CTCAE version 5. We will also be looking at several secondary objectives, including overall duration of response, local control, progression-free survival, and overall survival at 12 months. And we have some quality of life metrics. This will include recurrent non-metastatic cutaneous squamous cell carcinoma in patients where there is no curative standard of care options. And of course, we cannot allow any previously untreated squamous cell carcinoma. As Rafi alluded to earlier, this matches our FDA breakthrough status designation for squamous cell carcinoma. Based on the statistics, we will be enrolling 86 patients. All patients will undergo CT simulation. The sources are 3 microcurie, and this trial allows for the treatment in local anesthesia. I think this is very important because when we think about logistics and we think about resource utilization, the fact that the DART does not require either a radiation vault or a specific lined room in order to do the treatment is critical because it allows the physicians to continue to do all of their normal treatments, but in addition, add on the DART. The patients will come in for DART insertion on day 0. Removal will be 14 to 21 days afterwards, and then they will have a follow-up. So just to look at some other indications, this is our trial that's currently open for men with prostate cancer. This is a neoadjuvant prostate study. it's looking at the primary objective of feasibility and safety, as well as evaluating pathologic and radiological overall response rate, and looking at quality of life metrics, excuse me. So in these patients, they must be resectable at the time of initial evaluation. They have to have non-metastatic disease. The lesion can be up to 3 centimeters in longest dimension, and they have to have had no prior surgical or radiation to the pelvis. This is a pilot trial, so we'll be enrolling 10 patients. Treatment planning is based on either PSMA PET or multiparametric MRI for target delineation. The source strength here, as you can see, is slightly higher at 5 microcurie. This is all done under general anesthesia. The patients have the darts inserted on day 0. They undergo surgical resection on day 50. They have interim follow-up as well. So I'm just going to show you now a video of how we're doing this.
Revolutionary alpha emitters radiotherapy. The alpha plant applicator. Alpha Tau has developed the alpha plant applicator, designed for the delivery of high conformal alpha radiation into the prostate. This applicator could potentially be utilized in multiple clinical settings, including but not exclusive to focal therapy, recurrent disease following radiation, or in combination with current radiation therapy options. A live ultrasound is integrated with a treatment plan made on a CT or MRI prior to the treatment. The virtual grid of the treatment planning software is synchronized with a physical grid located on a stepper. Using a stepper, the physician navigates the ultrasound to reach the base of the prostate. The physician uses an alpha plant applicator with the appropriate number of sources in accordance with the treatment plan and inserts it through the grid's hole according to the treatment plan. The applicator is inserted until the tip of the needle reaches the desired position. To deploy the loaded alpha dart sources into the tumor, the physician removes the silicone holder and unscrews the safety lock. Next, the physician pushes the stylet until the safety lock touches the silicone stopper. This action brings the sources to the tip of the needle. Then, the physician holds the stylet and retracts the needle, while the alpha dart sources are designed to remain in the tumor and release alpha emitters into the tumor. At the end of the procedure, the alpha plant applicator is removed. The alpha emitters diffuse into the tumor and emit alpha radiation, which is known to create double-strand DNA breaks and tumor destruction.
So the next trial is
Alpha Tau,
is
treating
our
cancer.
pancreas trial. This is a feasibility and safety study of DART in pancreatic cancer. This trial is open in Canada. We are evaluating the feasibility and safety of DART insertion into the pancreas, as well as evaluating efficacy, overall survival, stent durability, and quality of life. This includes patients with locally advanced or metastatic pancreatic adenocarcinoma who are inoperable due to either having unresectable disease, metastatic disease, or being medically unfit for surgery. There's no concurrent chemotherapy or immunotherapy in this patient population. Patients are undergoing CT-based planning, 3 microcurie seeds, and this is all undergoing under general anesthesia. We have a total sample size of 30 patients. Sources are being inserted on day 0. Patients are coming for checkups, as seen here, and we have a follow-up of up to 2 years duration. As I tell physicians, when people think about device companies or drug companies, they think about different types of devices. Really, what we're focused on in our pipeline is really different engineering solutions to get the sources to the tumor where they need to be. And so for this cases, we're using the loading device, which allows you to basically use the endoscope as the delivery mechanism for the delivery of DART sources. The next trial is our two-stage hepatectomy trial, which I alluded to earlier. So this is a feasibility and safety study of DART for the treatment of liver metastases. And this was primarily going to be colorectal metastases as the most common metastasis to the liver. So I just would like to take a moment just to walk you through exactly what's happening in this study. So patients will present with either single large focus of tumor or multiple foci of tumor. The first stage of the two-stage hepatectomy is for the patients to have removal of the tumor on one side of the liver. Once that's done, we will insert DART seeds in the contralateral liver. They will ligate the portal vein, which will cause this part of the liver to grow. When this part of the liver grows after about 4 to 8 weeks, it will reach about 70% of the total liver size. They will then remove the other half of the liver where we had already implanted the DART seeds completely. So now the patient is left with about 40% of the total liver size as a functional liver, cancer-free. The beauty of this is we'll be able to study several things. First, we'll be able to look at the impact of DART directly onto a tumor metastasis. But in addition, in patients in which there are multiple metastases, we'll also be able to look to see, does treatment of one metastasis with DART, how does it impact the other metastases that were not treated? And so here you can see, this is a feasibility and safety study. We'll be looking at both pathologic and radiologic response. We will look at the immunological effect, as I mentioned. And the other thing we'll be able to do is actually stratify by histopathological growth patterns. So this is very fascinating that different liver metastases, depending on how they grow histopathologically, will either respond to anti-angiogenics or respond to immunomodulators. And so based on that, we will be stratifying between these two growth patterns to understand how the DART impacts. Finally, I would like to just show you some initial efforts that we've done with glioblastoma. So as Rafi mentioned earlier, our second breakthrough device designation was for DART in the setting of glioblastoma. So here what you can see is looking at DART and Avastin in combination for GBM xenografts. So we have 4 arms to this. The first in black is treatment with control. So either an inert seed plus IgG. In red is Avastin alone. In blue is DART alone. And in green is combination. So what you can see here is that once the tumors reach about 50 cubic centimeters, the mice are enrolled. You can see that after approximately 21 days, the tumors have grown to over 1,000 cubic millimeters and need to be sacrificed. Here you can see treatment with Avastin alone, which is currently standard of care for recurrent GBM. You're able to slow the growth, but you can see that by 28 days, again, the tumors are growing to such a point where the mice have to be sacrificed. Here you can see a single DART insertion alone dramatically reduces the growth of these tumors. But fascinatingly, in combination of both Avastin and DART, you can see we have mice over 40 days out with controlled tumors. So how do we go about delivering the DART seeds with this in the context of GBM? Clearly, we cannot use the same type of approach as we do with temporary implants. So we'll show you now our radical.
Revolutionary alpha emitters radiotherapy. The alpha radial applicator. Current treatments of brain tumors still provide results with a poor prognosis. Alpha Tau has developed the alpha radial applicator, which is designed to distribute the alpha DART sources in a precise spacing while potentially minimizing the damage to the brain. How it is used. A stereotactic navigation biopsy needle is inserted into the brain until it reaches the desired depth and location. The alpha radial applicator is affixed to the biopsy needle hub. The physician opens the needle's window and pushes the flexible applicator tube into the tumor. Once the tube is in place, the physician pushes the stylet forward and retracts the tube. Once the source is deployed, the needle is rotated to the next position. This way, a layer of alpha DaRT sources is evenly distributed around the needle without the need to reinsert the needle repeatedly. After the first layer of sources has been inserted, the biopsy needle and the applicator are drawn upwards to deploy the next layer of sources, as may be necessary per the relevant treatment plan. At the end of the procedure, the biopsy needle and the applicator are removed, while the alpha DaRT sources are designed to remain in the tumor and release alpha emitters into the tumor. The alpha emitters diffuse into the tumor and emit alpha radiation, which is known to cause double-strand DNA breaks and tumor destruction. Alpha Tau, treating cancer with precision.
Physician's normal practice. So for example, in GBM, the navigation system we are using is what the neurosurgeons use every day for the purposes of biopsy. So from the physician user experience side, we want to make it something that's very comfortable for them and within their wheelbox. Because we know that anytime you make changes to things, it is another barrier in terms of uptake and applicability. So we've tried to minimize that in terms of the physician and experience. I will say one of the things that we've also done is we've integrated a user experience for each of our new devices as we bring them forward in the clinic so that we can go back and refine and see if we need to make updates to them in terms of new versions. So with this, I'm going to turn it over to Rafi.
Great. Well, thank you very much, Bobby. All right, I'm going to wrap it up just quickly summarizing where we are clinically, where we're going forward. I think you guys have gotten the impression that we're quite active, have a lot of things going on at once, but I think hopefully is a little more order now in terms of the things that we're working on. And so you all have access to this. By the way, the presentation will be on our website after this is over. So hopefully there'll be some helpful to have some of these materials as reference. So we've talked about, of course, during the course of this discussion, our upcoming, both our feasibility study that we finished in the States and our upcoming squamous cell pivotal study. We've talked about the pancreatic cancer trial in Canada, looking for its first patient very soon, and liver cancer, which of course still is in planning. We've talked about some of these other points as well, whereas in Europe, in Israel, we have our prostate cancer trial, looking to open another pancreas cancer trial, as well as a combination trial with Keytruda. Again, trying to utilize some of that effect that Dr. Den spoke about, which is that systemic effect coming out of the local treatment with DaRT. Right, our focus here really is on taking our first indication, the superficial skin or head and neck tumors, pushing it forward towards approval in the States as quickly as we can. And that is, of course, where that pivotal study comes into play. I would note, of course, we already approved for that indication in Israel. We can sell this for squamous cell carcinoma of the skin of the oral cavity. And so, of course, we are pushing that around elsewhere in the world. As Bobby said, we're going to be applying, hopefully this quarter, for our PMDA submission for head and neck squamous cell in Japan, and then the pivotal study in the US taking us towards approval there. The other half of our clinical trials, as you've gathered, are focused on testing out different indications. Some of the ones that we've already spoken about, the pancreas, the prostate, moving into the liver, the GBM, et cetera. So if you look at where we are and what we expect to see over the next couple of months, the next quarters, so again, we should see already in the remainder of the year, we expect to see not only the submission in Japan, as we discussed, for our head and neck squamous cell carcinoma approval, but also see our first patient coming into the US and hopefully many thereafter for our pivotal study, as well as, I'd say later in the year, seeing the pancreatic cancer trial opening up in Canada, in parallel looking to open one in Israel and potentially Europe as well to speed that up. And then as we look towards next year, we should start seeing, assuming that the Canada trials opens as expected by the end of the year. So look for interim readout from that data by the middle of next year, together with data from our prostate cancer trial and potentially even PMDA approval, and then wrapping up the recruitment on our US pivotal study by the second half of next year. So a lot of exciting catalysts here coming ahead of us as a company with many shots on goal, of course. So with that, I'm going to stop here and take any questions, both from those in the room and then eventually to people on the phone as well. We have Jeff here, but Christine, I saw somebody over there earlier as well. I promised we'd come back to them.
Thanks. Just a few, Jeff Cohn and Loudenberg, I'll throw them all together. So firstly, Dr. Zalewski, could you hypothesize on the partial response patients in the second study that you discussed earlier? And can you talk about the placement of darts internally as far as them being removed or not removed? And then can you also discuss the density or location of the darts per size of the tumor?
Sure, we'll pass it to Michael. Before that, I want to clarify, you mean the partial responses from the first study, right? The second study was all complete responses. You mean the first study you presented?
Yes.
Okay.
As far as the partial responses, I think that needs to be even studied more carefully, because in that early study, it's quite possible that a contributing factor could have been whether fully the dose was delivered to the entirety of the tumor. Relatively recently, innovative approaches in terms of treatment planning and delivery, utilizing CAT scan-based modeling and treatment planning has been really a part and parcel of this therapy. And I think the second pilot study, which reflects really a complete response in everyone, may actually be reflective of that. But we all know that any kind of tumor is never going to have 100% response. And there are many, many factors obviously associated with less than a full response. So there are clearly biologic factors that are associated with less than an optimal response as well.
I'll just piggyback on that point a little bit. So if you look at the responders over time, you'll find that in the first study, all of the partial responders were in the first half of the study. So there are two reasons for that, multiple reasons, but two major reasons. One is that for the first couple of patients, because this was the initial trial in human, so the first couple of patients were not fully covered in terms of their tumor treatment. There was concern amongst the physicians about what the response would be to direct alpha treatment into a tumor. This was a brand new technology. So a couple of the patients we know specifically were not treated. So it's not surprising that they didn't have a complete response when you don't completely treat the tumor. So that's one reason. The other reason, and the other thing that we've seen, and really our COO, who's in the back, Amnon Gad, has been really instrumental in, is really building out our training program for physicians. So if you look at any type of surgical study, what you will find is that there's a direct correlation between outcome and experience, right? And the more complicated the procedure is, the more experience one needs to have before mastery. And so one of the things that we found early on is that we could build out a template, both in terms of lectures that we provide to the physicians, hands-on training that we provide to the physicians. We've also integrated a whole model system, both a general model system. We've also been able to, with collaboration from other companies, actually build the model of the patient's tumor so that the physician could practice on it prior to the actual procedure, which gives them a three-dimensional reconstruction of the tumor. So we can take what we see on the treatment planning, as Dr. Zalewski's alluding to, and actually actualize it in the tumor treatment as well. So we've seen that ability to really take all of the different components and really bring it to training and bringing the expertise up very, very quickly. We've seen the results in the US trial. Dr. DeAndrea could probably speak to this more, but after one or two treatments, the physicians using the educational model system that we built in have gained remarkable expertise in this planning and delivery.
And if I could add one point from just experience in brachytherapy in general, is that head and neck actually represents one of the most challenging and complex areas, because the geometry of the disease and where it's located can be very different in the neck, in the back of a tongue, in the cheek, and in other places. And there are going to be challenges as well in these other sites, GBM and pancreas, et cetera, et cetera. And I think what Dr. Den had mentioned, which is really on target, is that this source is likely to be associated with very high and excellent local control outcomes. The challenge is the engineering solutions, and that's what this is all about. And the group at Alpha Tau has really had an excellent handle on working on that.
Did we get your questions? There were 4 parts there. Did we get most of it? Sorry, Kristen.
Hi, this is Kristen Kluska at Cantor Fitzgerald. I have 2 questions. The first, Dr. DeAndrea, when you walked us through all those case studies, one reoccurring theme was that despite this being an experimental treatment, it seemed that your patients were trying to avoid surgery at all costs across that group. So wanted to ask if this were to be commercialized, what you would view as some of the main advantages outside of the efficacy, and then also how the Alpha Tau team is thinking about potential advantages for targeting some of the internal tumors.
Well, I think the advantage of this treatment is speed and convenience. Radiation, external beam radiation therapy takes about 6 or 7 weeks, Monday through Friday. Got to take your time off to work to do that. Then have someone to drive you if you're too old to get there. Very hard for the patients to get in there. The rural area is actually key because the distances are so long, and to go one place to another takes hours. So if the patients can come in, get the therapy implant, go home 2 weeks later, get it removed, that's a game changer, because again, all the associated cost of gas nowadays, you have to look at that, time of the family members, the patient themselves. All these folks are farmers and they want to go out and feed the cattle, and like, I've got like 10 minutes to get my treatment, get out of here. So so you have to look at that too. Now also look in the urban areas too. If you're busy, you don't have to take time off and try to go from uptown to downtown and try to get treatment. Try to do that for like a couple of days, okay? You know, so you'll say whatever gets it off faster because I have my business to do. So these are also very convenient for folks who have a very busy life schedule. You get the implant and then within 2 weeks, take it away. The nice thing about these things, you could coat them with a little rubbery mechanism, and basically you don't see them if not on your hands or your face. And so basically you can be being treated, no one even knows you have them on. So very convenient, very helpful for as far as the economical patient costs, as far as the time and the family time. So that, besides its treatment efficacy, is very helpful for the patients.
Sorry, can you elaborate on the question on internal organs? What was the?
Yeah, and then the second question was just, you know, again, outside of efficacy, safety, things like that, what do you view as some of the advantages when you're considering the internal tumors?
Oh, so for the internal tumors? Yeah, so besides efficacy and so what I would say is as follows. So not every patient is operable. So for those non-operable patients, it gets to very similar to what Dr. DeAndrea spoke about for external beam radiation therapy or chemotherapy. The DART is a single procedure. So it's akin to surgery in terms of the necessary time off, in terms of all of the logistics around it. The benefit is that the patients don't have to remain in the hospital. They're able to go home same day, which is a huge advantage over a lot of the surgical procedures that are done. The other advantages is that the sources are biocompatible. We have biocompatibility, and we're now doing full testing of biocompatibility for permanent sources. But we've already done biocompatibility and gotten approval by NAMSA, and we're doing now for permanent sources to be able to leave them in forever. They are completely biocompatible stainless steel seeds. Remember, every atom of radium that is on the source will decay to lead. And the half-life of radium is 3.7 days. So the amount of radiation on the source itself after 2 weeks is about 6% of the original activity. After about 30 days, so you've gone close to 10 half-lives. Essentially, the sources are considered inert at that point. They actually have less radiation on them than a banana does. Just put it into a context. So when you're eating banana, know that there's radioactivity you can measure on the banana. But the point of that is that, you know, we're looking at multiple different seed materials that we're exploring as well. So there's a lot of R&D going on. And in addition, in terms of the R&D for all of the internal organs, we have, I didn't allude to this, but besides just a small animal model platform, we also have a large animal model platform. So we are bringing this through using CROs in Israel to really test everything in the large animal model system before we even get to the first human trials. So we work through all of the logistics in and around that aspect as well. So that gives us further confidence in the delivery mechanisms that we have.
And then maybe the last thing I'll add, and I've got 3 doctors here to hit me if my 6th grade anatomy is off, but I think that one of the advantages I see here in giving us the ability to treat tumors that may have few other available options is you think about the nature of the axis you need to stick a dart in down an axis versus what you would need in terms of maneuverability and navigability to resect it, right? So take, for example, the example we showed with the loading device of the pancreas, right? So you may not be easily able to resect the pancreas, and certainly in a minimally invasive setting, it'd be almost impossible, right? But the idea that you can come down the GI tract and just shoot out this little dart and stick it through the axis into the, through the abdominal wall into the pancreas allows you to, and then allow it to continue to release its radiation. And as Bobby said, the fact that it's still there afterwards is sort of meaningless in our view. So that opens up the ability to treat a tumor where if you had to, I get questions all the time, people saying, well, hold on, you must need 3 ports, right? You need 1 for a camera and 2 for navigation. The answer is no. You literally have 1 entrance, minimally invasive, you shoot it out and you leave it there, and you can get to tumors that otherwise would be significantly more difficult to treat if you're trying to resect them. And obviously with a localized approach, that could be much more dangerous if you're doing a more broad or external beam type radiation.
I'll just add one last point, is that it's also important to remember that in cancer therapy in general, we really think about it from a multidisciplinary lens. And so the benefit of DART is that because our safety profile is so favorable, it doesn't preclude the utilization of other therapies, either in combination or in sequence, right? So all of a sudden you can take a patient from a stage of inoperable to potentially operable. You can increase local control in combination. So it's not that it has to be standalone. It may be standalone, but it can also be done in a complementary setting as well, which is very important to think about. So it's another quiver, as you were, for the oncologist.
In the clinical setting,
Correct.
in the trial setting, most of them are monotherapy trials.
Correct. In the
Commercial
clinical
use,
setting.
I agree.
In the clinical setting, which is, the commercial use, so you have a much bigger, broader indication. I think there was another question.
Yeah, let's get you a, you good?
I can go last.
Sorry, you had another question?
Yeah.
So.
I just want to also mention that these
Sorry.
seeds are not unique in the sense that there are other seeds that are commercially available now. They're used in the old system, so implanting. So these actually can be converted to use just like old seeds, or we did seed implant in the prostates, head and neck. I did actually CT guided seed implant in the lung tumors, pancreatic tumors. So that's before this technology was even available. So this is even better technology than existed before.
So follow up for Dr. D'Andrea. Can you just share with us the reimbursement end of how, when you're using the treatment on patients today, how are you dealing with reimbursement? And then also just other physicians in your practice, are they also, experimenting with the use of alpha tau technology? And if not, what's kind of holding them back?
Okay, first of all, this is a FDA trial, so these seeds have not been approved for Medicare, I think, for payment for Medicare. So we're not getting paid for the services. But if you look at the brachytherapy costs, just in non these seeds, but these other seeds, the seeds are reimbursed at Medicare rates will be reimbursed 100% of the cost of the seed. So if the seed's $5,000, they get reimbursed $5,000, $10,000. So the seeds are reimbursed separately on top of the procedure itself. And so if this is done in hospital OR, you're going to have the OR cost of the hospital, then the surgeon's cost, the anesthesiast cost, the physician's cost, and the actual seed cost themselves. So the seed actually is kind of a good deal because the hospital will get reimbursed 100%, or the outpatient center will get reimbursed 100% of the seed cost. Once that's developed, I'm sure Mr. Safar can talk a little more about that.
Yeah, and in terms of the reimbursement, I'll just say, obviously, we haven't set a price yet because we're not yet commercial, as Dr. D'Andrea mentioned. We have looked at some comparables out there from the market. We look at what radiotherapy is being reimbursed by CMS. Depending on the form of radiotherapy, it could be anywhere from $20,000 to $30,000 for a regimen, at least last time we looked. From our perspective, that's probably a floor because we'd like to believe we're a better form of radiotherapy. We come in often as a later line after radiotherapy has failed. Obviously, to the extent we see data supports use in some of the higher unmet need tumors like pancreas, like GBM, et cetera, to the extent we see that we can reproduce and harness that systemic effect we've talked about and end up functioning in some ways like immunotherapy, then the pricing points you see there, the 50 to 100K, become more relevant. But I would certainly say conservatively, we see that 20 to 30K as a floor seems pretty reasonable. But that said, I agree with Dr. D'Andrea. He's not had to deal with this yet because this has only been in a clinical trial setting. It's mostly on our side right now.
But from historical points of view, because I did use brachytherapy before, so it's going to be kind of the same idea.
Yeah.
Well, one of the other points that needs to be made is that this needs to be deployed in a very accurate way. And obviously there are physicians who are skilled in the placement of needles, surgeons, interventional radiologists, and radiation oncologists as well. And so not everybody is going to be able to do this. It's going to be the radiation oncologists who have skills, who have training to deploy it. And the same surgeons have this ability as well if they're operating in this area. And the same goes with interventional radiologists. And so these are the people who are going to be significant participants in deploying or utilizing the technology.
Yeah, and that's why we have that training program that we've been using for rolling out to these doctors.
That's correct. Actually, there's more that we're not on there, but those selection, yes.
On this subject that you've been discussing about the relationships you've developed with the practitioners and the training, could you explain to us how that dovetails with one of the last slides where you kind of went over your different geographies? And I mean, like in North America, for example, is it that you've established certain key relationships in Canada that relate to internal organs? Because I think you had stuff up about liver cancer or something. And then you obviously you're talking about skin cancer in the US, and I forget what you were showing for Japan, but is that related to that? And then can we also expect that as you share the wonderful things that you've accomplished and you kind of develop more relationships with surgeons, is that what's going to kind of like lead to the timetable of other sorts of trials in whatever, North America or some other geographies?
Yeah, I'll address that if that's okay. So in general, I'd say our focus is on bringing this to market in the US as quickly as possible. That's undoubtedly our largest commercial opportunity. And from our perspective, it's the one where we want to start. I'll remind you, for example, we are approved to commercialize in Israel and we haven't started selling there. We think our best strategy will be to launch here, secure the best price that we can in the States, and then move from there to other geographies. And so what we do is ultimately focused primarily on bringing to the States as quickly as possible, but not exclusively. We are looking to help people around the world with this. We are running multiple trials around the world. And as I said, applying for approval, hopefully later this year or later this quarter in Japan, to ensure that as we launch in the States, we can launch in other places as well. That said, you note correctly that many of our trials are initially based outside of the US. Part of that is sort of tactical. We find that trying to go as a company based overseas and with most of our preclinical work done overseas, going to the FDA to start up in humans in the States is often more difficult than it is in other countries or if we had US preclinical work. And so whereas we may go to the FDA and say, look at our fantastic Israeli preclinical work, for example, can we start treating humans? They might say to us, well, why don't you bring us some American pigs and American, cows, et cetera, and then we'll talk about it. But if you bring them data, not to be coy, you bring them data from Israeli and Italian humans, well, the Israeli and Italian humans are no worse guinea pigs than the American guinea pigs, right? And so they may not give you credit for efficacy, but they may say, I get it, seems to work very safely, let's go. And they'll give us our IDE very quickly and we can start treating patients. And so our strategy has generally been from a tactical perspective, where we have what we believe is a good principal investigator outside the States who can get a trial up and running quickly, a high quality trial. We'll do that and we'll then import that data and use it as the basis for a US study. It also means that we come to the States sort of fully baked. We've worked out any kinks in the product if we need to adjust some of the applicators or the way they're being delivered. We know that when we come to the States, we're going to run our US pilot study and have 100% complete response. So that's sort of been it's actually been on purpose, I'd say.
I'll just add that we've really cultivated relationships across centers. in addition to individual physicians. So we're creating centers of excellence, both the US and worldwide. And when physicians see the technology and the potential, they quickly realize that it's not necessarily for a very singular indication, but really can work across multiple different oncology spaces. And so what we've done is by creating these centers of excellence, it allows us to meet different surgeons, different oncologists in the different areas, and really allows them to get experience with the DART in one clinical setting, but then quickly open up trials in other settings as well. So we think that will be a way to really expedite our clinical trial process and then commercialization.
Just from a clinical point of view, I'm a little frustrated because I'd like to use these on other patients who had recurrences, patients who have anal cell cancer recurred, and they don't want to have surgery. These would be excellent for these patients. Breast cancer, a whole lot of patients who want to have this treatment, I can't get it because of the FDA issues.
From your lips to the FDA's ears, right?
Yeah, you know.
Sorry, yes, please.
This is Yuan from B. Riley Securities. So we are curious, why do you guys choose radium-224 rather than other alpha emitters like 225 actinium or 223 radium?
Sure. So the question was, why are we choosing radium-224? And I'm going to go back to my slide for a second, which I'll use it as a support here. But really the point here is about the decay chain that's built into the radium. So if you look at the decay chain here, which includes multiple breakdowns of alpha, right? The other forms of alpha-based therapies that you're familiar with, mostly the targeted alpha therapies, are using isotopes like actinium, which may have only 1 or 2 step breakdowns and release an alpha, and that actually works very well for them, right? Those are a different modality, a different solution for a different problem. Those are often systemic therapies injected into the bloodstream. We'll have some sort of targeting mechanism like an antibody pushing up the surface against the surface of the tumor, attaching to an antigen. And you want during that 1 or 2 breakdowns to have it in proximity to the tumor in a higher proportion versus other areas of the body. And so there actually the short decay chain works very well, because if it had a 10-step decay chain, the last 8 of them might be floating around the body and doing damage. In our case, it's the opposite, right? In our case, remember, we need to have multiple decays because the first one is going to happen on the source. It's actually the later ones that happen as the isotopes have moved into the tumor that give us that extended range to the alpha radiation. And so we need something that has multiple alpha steps along the chain, because it's actually the later ones of that decay chain that are getting farther and farther away from the source. The other thing is the half-lives here. So remember, the radium is staying fixed to the source. It's got a 3.7-day half-life. The rest, which is good for us, it's long enough to get it from our factory to the hospital and ready for use. The rest of the chain, though, which has about a 12-hour half-life, has a kind of Goldilocks mix to it. If it was longer, you would find it would live long enough to move outside the tumor and do damage in the rest of the body. If it was shorter, it wouldn't live long enough to diffuse away from the source and into the tumor. And so there's a good mix there where it's not too long, not too short, just long enough to give us that range.
Yeah, got it. It's very helpful. And maybe the next question is, in the past, we have learned a lot from locally administered chemotherapies, and some of them didn't yield some good results. So what can we learn from the past where some locally administered chemotherapy didn't have, but your DART could have some advantage over that approach?
I'm trying to think through the comparison. I mean, the locally delivered chemotherapies will be done locally primarily for safety reasons, right? To minimize damage
Or
elsewhere.
intraperitoneal or something.
Right, intraperitoneal, where you can cover it but keep it in the area. I'd say I don't see an obvious set of lessons there for us because our approach is a bit different. You guys have any thoughts on that?
It's very rare to put a local chemotherapy other than intraperitoneal chemotherapy or sometimes intrathecal chemo for the CNS coverage. So that's really not really useful in clinical setting at this point.
Right, those are generally liquids which are contained by either the peritoneal sac or the brain, right, in some sort of again, a very different approach than ours, of course. I don't see as many obvious parallels there, but I'll think about it and maybe we'll have a conversation on it another time.
Yeah, no problem. And one more from us. Maybe can you describe a little bit about the manufacture process? Like, where do you guys get the radium-224?
Sure.
And what's the supply chain status right now for that?
Sure. So the radium, we collect the radium from thorium-228, which breaks down naturally into radium. And as it does break down, we collect it and collect it on the sources and then sort of impregnate it into the source. The thorium is pretty easy to come by. We can buy it from the U.S. Department of Energy here in Oak Ridge, Tennessee. We can buy it from Eckert & Ziegler, which is a German nuclear medicine company. We've got a couple sources around the world. It's pretty easy to come by, and we use very small amounts. So that has not been a supply chain issue.
Got it. Thank you.
Thank you. I promised Kristen we'd give her back the mic. I apologize. She'll hold it against me if I don't.
That's not true. Kristen Kloska, Cantor Fitzgerald. Just going off the earlier part of the presentation, what are some of your early expectations on how long this immune system recognition of response could be for the longer term and the durability here, especially because a lot of the patients that you had treated with the Alpha DaRT had recurrences from that?
Bob, you want to start?
Sure. So I think if you can get immune recognition, that's a lifelong recognition. So in our mouse models, this was about a 4-month interval between the initial treatment and then the rechallenge. So in that time frame, the mice immune cells had recognized the tumor and therefore built an immune response to it. So we would anticipate that this would fall like any type of normal reinfection, or as long as the tumor didn't have a specific mutation which basically hid it from the immune system, it should be a lifelong protection. The idea would be that it would basically prevent future metastasis from occurring. And we see this in some of the other experiments I haven't shown you, where we have models of actual metastatic disease, where we can treat a local tumor and then look at what's the overall metastatic burden, where we're not treating, like, for example, the lungs. So we can treat in the hind leg and then look at the amount of lung metastasis that develop. And we consistently see a decrease in the metastatic burden in the mice that have been treated with DaRT. So we can see that there is an immune effect, and it's a systemic immune effect as well. But these types of rechallenge experiments and really looking at them over a time frame are experiments that we have upcoming in our pipeline, but haven't formally annotated fully yet. So I can't really comment fully on that. But I would anticipate just the way that the body is that once you've developed either a T cell response or B cell response to a particular antigen, you will maintain that for the rest of your life.
Thank you.
All right, great. I'll wrap it up just quickly with, I see we had one. Oh, sorry, one more. Sorry, please. Yes, so actually, sorry, the question for those on virtually was, do we have plans to combine it with anti-PD-1? We did gloss over this, but yes, we have a trial open now in combination with Keytruda, with pembrolizumab. This is a trial we opened late last year in Jerusalem for metastatic head and neck squamous cell carcinoma patients. It's an interesting trial because both the Alpha DaRT and Keytruda are approved in Israel for treating metastatic head and neck patients. And so it's effectively a combination of 2 approved products. Very keen to see how that one comes out for the reasons you can imagine.
And from a regulatory standpoint, what is
So the pivotal study we're running is not in a combination. The pivotal study, of course, is just in monotherapy. The goal there will be, I mean, Dr. Den spoke and Dr. Zalewski spoke about some of the data and some of the endpoints. It'll be focused primarily on local response. Again, this is a monotherapy trial focused on treating the particular tumor that's been chosen. And so we will be monitoring that for overall and complete overall response rates. Yeah.
For the treatment of internal tumors, say brain or pancreas, what are the drawbacks, if any, of leaving the needles in after the surgery permanently? And then if there is needed for a retreatment of a patient, are there any challenges when there is a need for retreatment?
Yeah, so in terms of, so again, those sources that are being used for those treatments are intended to be permanent. They are, from a regulatory perspective, intended to be left in the body. They are medical grade stainless steel, like any other stainless steel implant that's left in the body. And again, we've tested, as Dr. Den alluded to, that they're biocompatible, MRI contingent, they can be left in the body. We generally see that the tissue tends to heal around them, so we don't see migration issues being a real issue there. And so we're comfortable leaving them there unless there's a reason to take them out, right? If the patient is going to have a surgery anyway, for example, as in the prostate trial that we're running, the sources could have been left there, except this is a neoadjuvant surgery protocol, right? The protocol has the prostate coming out anyway, and so we'll have the ability to see those sources and actually physically see the histopathology of how the prostate's responded to the treatment. But were it not for that surgery, we would have been fine leaving them there as well. Now, the retreatment is an interesting issue because I'd say in general, we see that as a large area of advantage for us. Normally, these patients who are getting radiation oncology are getting pushed, 50, 60, 70% of the way to the cliff just because of the desire to maximize the chance of success with a relatively inefficient beta or gamma radiation. And so our advantage is that because we are dosing a fraction of what these patients can tolerate, we can treat them multiple times without an issue. We've actually opened up a protocol for retreating patients who already had the alpha DaRT for the superficial tumors, have a recurrence and want to come back and be treated again because the original protocols didn't allow it. I've sort of set myself up for this one, but unfortunately, we haven't had any patients there yet because we haven't had enough recurrences to have anybody come back. But in theory, we do have a protocol open for that.
Just to clarify, in your question, you mean retreating after a patient received DaRT before?
Yes. Yeah.
Yeah, so the only issue, the only challenge is just if there's some stereotactic issues where you have a seed here and you want to place a seed next to it. For the GBM, we have the ability, because of the way, and you can see in the back, we actually have it such that it's set on specific angles. And basically the surgeon can't put a seed in between the angle, the way it's designed. So what that would allow us to do in a retreatment, if you had a recurrence in the same area, you would be able to just off shift the placement. And then you would be able to basically recreate the radiation dose, but avoid having seeds essentially overlapping. So that's how you could actually retreat the same area in the same patient, recreate the same dosing, but actually not have the issue of like stochastic hitting of metal on metal, for example. And we could do the same thing for pancreas tumor as well. So that is a possibility as well. In the case where we're removing the sources, again, we have the ability to treat it in the exact same conformation that we did before. And remember that because of the sharp dose fall off and the fact that the toxicity is all very closely related to the area where we previously treated, if you have, it gives you a lot more flexibility. So when we think about retreatment, in general in radiation oncology, when we think about retreatment, we always say that we prioritize the organ at risk first, and then we look for tumor control second. But with DaRT, because of the toxicity profile and the sharp fall off of the source of radiation, we can actually continue to prioritize the tumor control over the organ at risk, because the organ at risk potential is much, much more reduced with DaRT as an example, as opposed to, for example, external beam radiation. So just another aspect to keep in mind.
Great. Well, thank you, everybody. You've been very patient, very gracious. For those of you on the phone, thank you for joining us. For those of you in the room, you can have a brunch, I suppose, by now. We're already after 12. So, and we've got a demonstration of some of the applicators in the back for those who care to see more. Thank you, everybody.